The problem right now, it's mostly the medical system we're in, and that is the insurance-based models that don't have ICD-10 codes that allow us to bill for applying preventative measures, and then a system where you have to have a symptom that's neurologic before you even see a neurologist.
Hi, everybody. Welcome to Be Empowered, the podcast, where we dive into the realities of healthcare and entrepreneurship. We offer our opinion, unfiltered, unapologetic, and always with a dose of empowerment. We're here to amplify voices, yours and ours, challenge the status quo, and explore what it truly means to thrive. So let's get into it. I'm Dr. Santoshi Bilakota.
I'm Dr. Shalom Mokba.
And today we have Dr. Tasha Powell. She's a board certified neurologist and founder and CEO of Longevity Neurology Center in Scottsdale, Arizona. Her perspective is unique. It's shaped by a diverse background, from treating traumatic brain injury and athletic populations in the U.S. military to drawing on the holistic wellness traditions of Alaska's indigenous communities and the Mediterranean culture from her youth. At Longevity Neurology Center, Dr. Powell blends science, preventative neurology, and personalized care. So thank you so much for coming on. Tasha, I can call you Tasha, right?
Absolutely. Please call me Tasha, unless you're my patient, but even then, you're a colleague.
Well, that's great. Thank you so much for joining us. As I was putting this together, I realized that you've had such a diverse background. I don't think I've met anyone with such a diverse background. Do you mind telling us a little bit about your journey in medicine and how this background kind of shaped where you are now?
Yeah, you're correct. Thank you for having me here, but you're correct in saying that I'm a bit unconventional. So I would say medicine became first on my horizon growing up in Yugoslavia. I have an interesting little tidbit here that I was born in Chicago, so I'm a US born citizen. But around age 2 or so, I was sent to Yugoslavia to be raised by my grandmother for various medical reasons my family had at the time. And so Yugoslavia, ex-Yugoslavia is officially considered part of the Mediterranean because a lot of the Balkans is on the sea there, the Adriatic Sea. And so I got to experience firsthand that life of the Mediterranean culture. But also I was trapped in that war in Yugoslavia. And while the war was a rough, tough experience, it did form what I wanted to do. It helped me decide that medicine was the only way to go when you see so many people around you that are harmed and hurt and bleeding and limbs blown off. And I was I was an adolescent at the time, and I just knew nothing, and I had no way, objective way, to help people around me. But the other part of that is during the war, it kind of reset the culture to become even more traditional because we had to look around the land around us and see how we can survive off the land. And we had to go back to the old ways of fermenting foods because we had no running water and electricity. So, how do you save and preserve foods? And we had to go back to that strong sense of community, which Yugoslavia had a baseline, but we had to rely on each other even more than we ever had before. So he kind of gave me this view of what it is to truly be. When people say living a Mediterranean life, I not just lived it, but it was part of the reason for my survival. And then, we all think of Mediterranean as the seafood and olive oil, but it's actually more than that. It's the real food, it's the community, it's the connection and movement and resourcefulness that was part of the Mediterranean. And then contrasting that life during that war and conflict and focusing on what strengths Mediterranean life gave you, it kind of made me as a baseline person that I'm biased towards action. I just want to move forward. What can I do? Optimize and prevent and treat things or take care of things before they get worse. And that's why I am who I am, I suppose. And this was further reinforced then in my training at Walter Reed. So I'm a military neurologist, or I was. I separated in 2017, but I trained at Walter Reed, which is called the President's Hospital for obvious reasons. We're there in the DC area and taking care of the Senate and the president and vice president and everybody else along the way. And being there, this is Walter Reed is the largest military institution in the world. And that meant that we took care of very healthy, young, high performance athletes, which are your soldiers. And then you have the extreme of, at the time that I served, Operation Iraqi Freedom and Operation Enduring Freedom was going on. So we had a lot of acute trauma coming through, concussion and peripheral nerve injury. And then, of course, being the largest military hospital in the world, we got all the weird, atypical neurologic cases from all over the world. So it gave me the nice breadth of experience to take care of those who are worried well and very healthy and high performing, and they may just have an occasional migraine I had to optimize and make sure that they have their sleep cycles optimized so they can go back into the war zone, to the extreme disability that some of our patients had. And I would say this exposure of the war in Yugoslavia, serving the country, so to say, a Walter Reed by being a military neurologist trained in this diverse background of medicine, has really set me up to see medicine from a slightly different angle. And that is the angle of how do I optimize function for as long as possible. And that's how I would say is what formed me who I am today.
That's fascinating. I actually trained at Georgetown, and we rotated at the DCVA. And I
Mhm.
remember there were so many patients that I had to transfer to Walter Reed,
That's
especially for neurosurgery. Some connection there. You probably, if we were at the same time, you probably have seen, or
probably where
your colleagues have been seeing my notes, for
I bet it's a
transfers.
small world, it just
Yeah.
listening to, the different people interactions I've had. Whoever's lived in the East Coast, it seems like at some point we must have shared patients or maybe even walked by each other somewhere in Georgetown. I still love Georgetown cupcakes. I crave those once in a while.
Oh yeah. Oh yeah. They're very good. So why neurology?
Yeah, neurology actually blindsided me a bit, you guys. I was trained as a mathematician in college, and I was very physics oriented. So black and white was my specialty. And I played the piano. Of course, every Yugoslavian Balkan woman plays an instrument. But I loved the hand-eye coordination that I had full expertise in, and I liked black and white things. So for the longest time, you guys, I thought I was going to be a surgeon, and surgery was so easy for me. I remember rotating as a third-year med student and doing the laparoscopic gastric bypass and laparoscopic nephrectomies. They allowed me to be first assist because it was like a video game for me. It was just so easy, so wonderful. So that was my pathway until, and this is unusual for most medical schools, but at Wake Forest, where I trained, where I went to medical school, they actually had third year rotations in neurology, which my understanding is most medical schools, it's a fourth year thing. So I was blindsided. And I remember thinking, gosh, everything is so complicated and everything's so interesting. And we spend so much time with the patients and we discuss all these big differentials. But the specific decision to become a neurologist was one single event. And I remember going into an exam room with this elderly neurologist who's been doing neurology for 30 years. And I can't remember his name. I only saw him that one time. We went in and we saw the patient, and I had no idea what's going on. I'm just a third year med student. Who knows what? Every part of the body had some symptom. And we walk out, and he just stood there, slightly perplexed and very curious. And he said, I've never seen this before. And I thought, wow, what a humble, transparent comment to make from someone who had enough gray hairs on his head to suggest that he should know everything, but he didn't. And then we spent some time researching and looking into the best workup and different differentials we can consider. But I remember thinking, I want to be that 80-year-old that walks out of the room and says, I've never seen that before. Because I like curiosity. I like complexity. I like to be surprised every day, which is partially probably why I'm a general neurologist. I never subspecialized. I like to see a little bit of everything, and it was that the humbling and beautiful experience of not knowing something, even though you have a lot of experience, and that's when I decided neurology is the way to go for me.
And so, what prompted the creation of the Longevity Neurology Center as opposed to a traditional hospital practice? I know we were talking about this a little offline.
Yeah, so Longevity Neurology Center has been a kind of a small thought in the back of my head for quite a long time. It wasn't a very defined, I know exactly what I wanted to do thought for a while. But my patients that I see now, they come to me and say, "Oh, you're filling in this gap, and you're supplying something that other neurologists are not doing." But that wasn't the reasoning, actually. I feel like what it was mostly me having a center where people can find me and they're ready to make the change that is needed to optimize their brain health. And what I did years prior, I had this unofficial approach. I would look at patients and think, okay, how long is it going to take me for me to convince them to do a meaningful change? Not just small changes like, quit soda or whatever, but meaningful change that can impact their neurologic health. And my average was about 4 to 6 visits before I can actually get those patients to make that change. And of course, I'm talking about some of my stubborn veterans and some of my Medicare beneficiaries who've been living, 40, 50, 60 years in this certain lifestyle. So it's really hard to make them move forward. But I figured, I'm going to live only so much and I'm going to be a neurologist for only so much. I need to maximize, get the biggest bang for the buck, not financially, but physically, how far I make it with my patients by seeing those who are ready to take that next step. And now, of course, we all have these patients that come in with their little notepads and pens, and they're ready to record me. And they're, within a visit or two, we're going to make some big changes. But that's maybe 10, 20% of patients. For the rest, I'm spending sometimes months to years before I get somewhere. So, long story short, having the Longevity Neurology Center, I figured I'd hang my own shingle. People can find me. They can see based off my really nice, pretty, elaborate website what I'm going to do for my patients, and they can decide for themselves, is this the approach that they're ready to do? Because I have frustrated some of my patients before. I've had a patient, gosh, maybe about a year ago, who came in and she literally barged in the door and said, "Doc, I just want the pill. Just give me the pill. I don't want to eat kale. I don't want to do all the stuff you're telling me. Just give me the pill." And I thought, okay, well, I'm wasting her time and I'm wasting my time. And I still try and go through the effort. By the way, that patient eventually, she came around and she's doing all the right things now. But for so many moves, having been military, I've lived in so many different states and cities. And then even after leaving the military, I've been kind of up on a go. My family, we have a Sprinter van, so we have over 120,000 miles in the Sprinter van because we like moving, we like traveling, we like camping. So moves have always been easy for me. But every time I moved, I had patients who would fly from the state where I was prior to see me in these new states. And so that was another hint to me. And the final hint was, I remember in Alaska I was seeing a patient who was moving to DC actually, and I had plenty of recommendations for her to get her migraine Botox in DC. And she's like, "No, I'm coming back to you every 3 months. I'm flying from DC to Alaska." And that's like an international flight. And I start asking why. Why is that? I can set you up with any other Botox, neurologist to give you your migraine Botox. And she said, "You give me more than Botox. After I leave with you, I am armed with so much information I can share with my friends and family that I feel like you rejuvenate me every time, and you re-encourage me to do what I need to do for my health." And again, that was another piece of information I needed to solidify this small thought that's been burning in the back of my mind to open up Longevity Neurology Center.
That's great. You have the time to spend with your patient and for your patient to feel that satisfaction. That's very valuable because most physicians that we talk to who are part of a hospital system or unfortunately part of another corporations or organization, they don't have that time. They're squeezed. They have only 10, 20 minutes with the patient. The rest of the time is admin time that they have to work on their charts. So I praise you for this, that you were able to do that and do the best for your patients and what is satisfying for you as well. Can you tell us more about preventative neurology and what is that? What is preventative neurology?
Yeah, it's actually simpler when it comes across. You think this complex approach that we have to apply to patients, but it's basically getting to the disease before it sets hold with you. And throughout residency and being an attending and working in various places, we always frowned upon or refuse those referrals for the worried well, right? For your patients that are healthy, but they're concerned about stuff. There's such a demand for what we do, we can't afford to be seeing patients that don't actually have a neurologic manifestation of their disease. We have to wait for that to happen. Plus, it doesn't help that in traditional insurance models, of course, you have to have the ICD-10 code to justify seeing the patient, right? And so, yet, those were always my favorite patients. I love seeing those healthy patients that are coming in and saying, "My mom had a stroke, my dad had dementia, my sister is going through some early memory problems with her perimenopause. I am very worried because I'm a single mom and I have 3 kids. What can I do to ensure that I have this optimal cognitive function?" And so those are my favorite patients. So doing the preventative neurology in patients that are doing well, but they have various risk factors or worries for these risk factors, are those that I can kind of dig deep and stratify those risks and give them, I don't want to call it a protocol, but give them a plan that's individualized to them. And you're absolutely right, Shala. I have to spend that time with that patient, and I have to, it takes a lot of effort to dig deep to their family history, the history, the family tree, your personal vascular risk factors, how do you eat, how much you exercise. Oh, if you already exercise, well, are you doing the zone 2 or VO2 max, and what is it? So, I kind of go into the weeds with these patients depending where they're at, and that takes a lot of effort and time. But the more time I spend with them, the more they become invested to respond to my recommendations. So it's kind of a win-win approach. But when you look at preventative neurology, it's optimizing things from sleep, your metabolic health, your vascular risk factors, what are your genetics. It is, and then even the psychosocial situation that you're in and how we can optimize that individualized to your particular person. You can have a 62-year-old that's drinking soda their whole life and never does any exercise, and I can have a 25-year-old that's, a elite athlete here performing and doing sports. My approach for recommendations, even though the overreaching preventative neurology approach is pretty clear, don't get vascular disease and eat healthy and exercise and have the Mediterranean diet, the way I approach those two patients are very different. Because if I give the 62-year-old what I'm telling this 25-year-old, they will never get there. They'll get scared and walk away and never come back to me. So I have to make things bite-sized and meaningful and approachable to them. So that is what preventative neurology is in my clinic, is knowing the data for prevention, maintaining, keeping up with that data because it's changing on a daily basis, it seems like it, and then looking at the patient and the individual circumstances of that patient and personalize how I can approach their preventative approaches.
Do you feel like you face any challenges from patients or even other clinicians in terms of preventative neurology? I feel like there are maybe people out there that are a little skeptical about how we can prevent certain neurological conditions because we almost, I won't say we're kind of accustomed to believe, but to a certain degree, we kind of think a lot of this is genetic, it's going to happen anyway. Can we actually make meaningful impact?
Yeah, that is such a great question because I am fully aware to this day, even as a preventative neurologist, which by the way is self-proclaimed, right? There's no fellowship, there's no, residency that teaches preventative neurology. It's just my hard work and doing my own CMEs and researching things. But the problem is it is less data these days and more so what we have out there in the environment right now. We have so many non-physician providers out there that are selling this snake medicine. I see it on a daily online, on Instagram. I'm driving by these clinics called Brain Center, and I walk in there, and it's a naturopath promising that they're going to reverse your dementia. So, going against that with evidence based data that suggests that we can prevent things while being mindful of, there's so much that an MD or a DO has to do in assessing the patient's risk and looking at where they are in their disease process and how I present that to my patient and their family as to what my expected outcomes are. So, for example, if I have a patient that has no dementia, but they're at risk for dementia because their ApoE4 is positive, heterozyg or homozygous. Or if I have a patient that has early findings of Alzheimer's dementia confirmed on neuropsychological testing, well, I can't promise them you're not going to get dementia, but I can promise them that if we do all the right things for you, we can delay the progression. And the same thing for my moderate to advanced patients, right? So I can't promise I'm going to reverse anything. All I can promise is that I can maintain your current function. So there's some realism about being a preventative neurologist, and that is that yes, it's true. Neurologists we're one of the probably only physicians that everything we diagnose has no cure practically. But then we have this wonderful evidence-based data that shows that we can, for instance, also, dementia. I was going to say Alzheimer's, but actually all dementia, vascular dementia, Parkinsonism, Alzheimer's. If you apply these vascular risk factor modification, it can decrease it by 40 to 60%. That is huge. And so using the data to educate people around me, including my colleagues, has been the most convincing part. I would actually say the biggest struggle in what I do has been less from my patients. My patients are ready. They want, they want someone to clear their minds from all the conflicting stuff they get online and from these snake oil salesmen, right? So they're ready. My colleagues, they're already by now, I feel like we've spoken enough about from me and from online and from the data and from the evidence. JAMA is posting, AAN's posting, neurology journals are posting about all this wonderful preventative data. I think the problem right now, it's mostly the medical system we're in, and that is the insurance-based models that don't have ICD-10 codes that allow us to bill for applying preventative measures. And then a system where you have to have a symptom that's neurologic before you even see a neurologist, right? So if a neurologist never gets to this patient and they may have all these potentials for developing these certain neurologic conditions, including things like peripheral neuropathy and stroke and dementia and exacerbation of migraines, and there's even small data for MS modulation with lifestyle choices and modification of the nutrition that you intake. If we don't get these patients early on, then we can't do anything about it. But yet, insurance models don't allow us to see these patients because they won't reimburse for it. So you're kind of in this crux of what can I do? And that has actually forced me to, or encouraged me to be a fee for service model where the relationship between me and the patient is sacred. You pay to see me, and nobody can influence whatever decisions I make with you. And then if I need to order imaging and labs and neurocognitive testing and EEG, EMG, then I can use insurance for what it should be used for, which is to pay for those expensive services that help us modify how we approach our patient for long term.
We're going to pause here for this week, but don't go too far. We'll be back for part 2 next week, and we'll tune into the rest of the conversation. Thank you.